Excellent. So, hello everyone, and thank you for joining us today for another episode of Pearl's monthly lecture series of 2025. And for anyone who is new here, Pearl stands for POCUS for Emergency and Acute Care in Resource Limited Settings. We are a nonprofit organization entirely run by volunteers, and we aim to provide free POCUS training to doctors around the world. And today we have a very special guest, one of our intensive care paramedic colleagues from Ambulance Victoria, Jack Donovan. And Jack will share with us his experience with pre-hospital POCUS. Thank you, Jack, for joining us today, and please take it away.
Everyone, thank you so much for that introduction and thanks for the invitation. So yes, I am an intensive care paramedic with Ambulance Victoria here in sunny Melbourne, and a PhD candidate with Monash Uni, looking into sort of paramedic point of care ultrasound in general. All right. So I have been a paramedic for 13 years, both in Australia and for a brief stint in the UK. I have recently, or maybe 6 or 7 months ago now, I finished my CAHPU through the Australian Society of Ultrasound in Medicine. So that's a certification in EFAST and vascular access. And I've also got a micro-credential in lung ultrasound from Monash Uni. So in my on-road practice, I have permission from our medical director to use ultrasound for sort of all purposes, but just with some restrictions in not making too many decisions with things that I'm not specifically credentialed in, but sort of as an early adopter for on-road use of point-of-care ultrasound for paramedics. And I've got a bit of a funny accent, in case any of you noticed, because I grew up in Canada. So as long as you don't ask me if I'm American, we'll be friends. So my other sort of, I guess, the research aspect of my interest in point-of-care ultrasound stems from my master's degree, where I did a research project with a colleague of mine looking at sort of a small pilot study for lung ultrasound for medical respiratory distress patients. So there's a lot of literature out there about paramedics using lung ultrasound for trauma, but not much in the medical respiratory distress space. So we did a pilot study on both that category of patients and also the difficult peripheral IV access patients. And that was really great. And it sort of spurred in me created in me sort of an interest and a passion for point of care ultrasound. And here I am years later doing a PhD on it. So it certainly bit me. So what I want to talk to you about today is a little bit about Australian paramedics and our context in general. We'll talk a little bit about what we're using point of care ultrasound for currently, and then where I see the greatest areas of clinical utility for the future. And that would be patients with dyspnea, cardiac arrest patients, ultrasound guided IVs, trauma. And we'll talk a little bit about some of the equipment that's out there that's being used by paramedics. I'll talk a little bit about my research, and I'll give you a couple of cases from my own practice that we can talk about to see how it sort of impacts my day-to-day. So being a paramedic is something that I'm not sure many medical professionals understand very well. Like, I know most of you guys would be aware of us and what we do, but not in great depth. So our sort of circumstance is that we're always time poor because we have these KPIs in the same way that you guys do, except ours are we've got 20 minutes. You get 20 minutes on scene and then you should be moving to hospital. And you can imagine the sort of circumstances we turn up to where people are, up in a bungalow or way in the back of a house. We have to get that patient out, decide what their clinical problems are, manage them all within 20 minutes. And if we don't do that, we've failed to meet our KPIs and, consequences, but not really. So we work in a very time poor environment, I guess is the point. We're resource poor in that usually there's one paramedic or maybe two on scene, unless it's a cardiac arrest, and then we get 4. So we're very resource limited in terms of staff. We're also very space poor. So we work in frankly, crazy environments, such as, hoarders' houses, crashed vehicles, upside down on the side of the road. I'm constantly surprised by the sort of situations we get ourselves into. And from an ultrasound perspective, what that sort of equates to is scanning patients in the back of a moving ambulance traveling 100 kilometers an hour on the way to the trauma center, which has a myriad of its own sort of challenges. But I guess I'll just give you a brief sort of contextual example about my state and how the paramedics work here. But I think you can apply this more broadly around the world and certainly in Australia. So this is what I like to call a taxonomy of ambulance. And essentially, we have three tiers of response. So tier number one is this largest section of our triangle at the bottom here. This is ALS paramedics or advanced life support paramedics. They're our kind of basic primary level of paramedic. There's about 5,000 or 6,000 of them in the state of Victoria. And they have, a fairly standard skill set for paramedics, IV access, a number of IV drugs, monitoring and stuff like that. And then in the next tier up, we've got our MICA paramedics, which stands for Mobile Intensive Care Paramedic. That's myself. That's the category I fall into. And then there's about 500 of them. So we're about 10% of the total workforce. And then on that top of the triangle there, we've got our MICA flight paramedics, who are sort of the tip of the spear. They've got all of our advanced skill set, and they are the ones using point of care ultrasound in most ambulance services around Australia. So then we've got our poor cousins, the non-emergency ambulance, who do sort of low acuity inter-hospital transfers, and yeah, they're privatized, so they're not really part of the ambulance service. They're sort of our poor cousins. And the basic paramedics will do a 3-year university degree and 12 months sort of internship graduate phase on road before they start. Intensive care paramedics or MICA paramedics, we go back to uni and do a further graduate diploma. And then we do anywhere from 18 to 24 months of sort of supervised practice before we're finished and ready to go. And our skill set includes things like RSI, video laryngoscopy, sync cardioversion, pacing, intraosseous access, and cricothyroidotomy. In some cases, such as myself, you can go out and do an extra credential in a couple of things. Currently, there's only really two, which is ultrasound and finger thoracostomy, but this is very uncommon at this time. And then our MICA flight paramedics go back to university again and get a graduate certificate of aeromedical retrieval. They've got all of those previous skills plus finger thoracostomy, pediatric RSI, ultrasound for EFAST and vascular access. They've got iStats and arterial lines as well. This is just to give you an example of how spread out our workforce is. This is the state of Victoria, and as you can see, there is a huge pile of overlapping ambulances all centered around our major city of Melbourne. And then, there are huge tracts of probably mostly unpopulated space out in the state where there's not very many ambulances at all, and the distances can be quite significant. So let's get back to ultrasound now. I'm sorry for that little diversion. I just feel like it's good for context for you guys to understand sort of the background. So in terms of who's using point of care ultrasound in Australasia, I should say, as I said, largely it's these specialist flight paramedics that are using it. And it was almost exclusively introduced as part of a bundle of care for trauma. There was this idea that if you were going to be giving blood products pre-hospitally, that you had to have access to ultrasound. And so in about kind of somewhere between 2012, 2015, we started seeing these point of care ultrasound devices out on helicopters. And that sort of stagnated for a really long time. There wasn't a lot of extra stuff being done. It was all just EFAST, and it wasn't sort of well taught, and the skill there wasn't a lot of upkeep. It was sort of, here's your initial training and off you go. No one's ever going to look at your scans again. So that's changed now, and we've got sort of a lot more interest in it and a lot more interest in its potential use for paramedics. We've now got the Queensland Ambulance Service High Acuity Response Unit paramedics who are sort of like Micah Flight, specialist flight paramedics that work on a car on the road. About 25% of the time, they work with a physician, and they're using ultrasound at a really, really high level. Their training is exceptionally advanced for paramedics, and to the point where they can actually bypass ED and go straight to theater based on a paramedic performed ultrasound, which is pretty amazing. And then the other sort of, I guess, really important development is in what we call community paramedics, and these are specialist paramedics. So they go back to university and they do a master's degree, but they're focused, rather than being focused on the critical care, intensive care side of things, they focus on the extended care or low acuity applications. And they've started to bring in ultrasound to their practice. I think it's somewhat limited compared to the intensive care applications, but it's expanding every day. And I think that's probably where most ambulance services are investing their energy these days. So what's it being used for? The vast majority is EFAST. Some services are expanding that to echo and cardiac arrest, but it's sort of in a very ad hoc basis. It's not sort of formally taught. It's more of a, well, as part of your EFAST scan, you're getting this subxiphoid view. So if you go to a cardiac arrest patient that you think is a PE, put it on, see if you can see anything. Lung ultrasound for medical respiratory distress is being explored in a number of jurisdictions, including in New Zealand, which I think has some really exciting applications for us. And finally, ultrasound guided vascular access, which has got to be one of my all-time favorite uses for ultrasound and what I probably use it for the most on a day-to-day basis. So where does the clinical utility lie for us? I think very much for lung ultrasound, yes, the pneumothorax identification is a really big one, and that's historically where a lot of the research shows that it's beneficial for us. But as I said, the medical aspect of lung ultrasound is a really interesting space for paramedics because we don't have access to traditional imaging. We're basically just guessing, and I'll talk a bit about that more. For EFAST, I think this is a really fascinating subject, and I'll talk a bit about my research in a minute, because even though we use EFAST to identify hemoperitoneum, in Victoria, it doesn't really change anything for us. It doesn't really change anything for the hospital. It's just something that we've been told is part of this bundle of care, but it's not actually affecting our decision making. It's not affecting patient management in a lot of situations. Pneumothorax identification has been a really big one for us because it stopped a lot of iatrogenic harm from unnecessary chest decompressions. And hemopericardium, again, is really interesting because we don't have the ability to actually manage a hemopericardium or a tamponade. All we can do is identify it, and it's exceedingly rare for us to see one. Finally, vascular access, yes, massively improved success rate and decreased use of IOs, especially in trauma patients. I think it's really beneficial. So let's talk about shortness of breath. 1 in 7 of our ambulance callouts in Victoria are due to respiratory distress or shortness of breath. So it's an enormous cohort for us. The patients that are transported by ambulance often have a high morbidity and mortality. And interestingly, importantly for us, they're almost always undifferentiated respiratory distress patients. They often have overlapping pathologies. It's very uncommon for it to be a clear-cut case of, oh, yes, it's asthma, or, oh, it's pulmonary edema. We have a very large comorbid population with these multiple overlapping pathologies. And we're relying as paramedics on just clinical judgment, history taking, and chest auscultation. We don't have any other tests available to us. And we like to think we're really good at picking the right cause, but evidence would show we're not so good, and we only get it about 50-60% of the time. Whereas, we use lung ultrasound, take lung ultrasound into account, and it is just a fantastic tool. Even like, it's so simple to teach it. It's so simple to interpret. I absolutely love it. And it has made such a big difference to my practice to be able to, say with a much higher degree of certainty than I've ever been able to before, look at this large pleural effusion or look at this consolidation that we've got here. Um, I can't tell you the number of times when we've gone, oh, I think this is pulmonary edema. We'll manage it with CPAP and furosemide and GTN. And then we get to hospital and they go, oh, no, it was, a big pneumonia or something like that. Very common for us. Trauma. Interestingly, just like a bit of statistics for you. So in 2021, 2022, um, there was over a million, I think just over a million ambulance call outs in that year in Victoria, and only 3,460 of them were major trauma. So it's an incredibly small part of our workload, but where a lot of money and effort goes into from the service. So where it helps our microflight paramedics is decisions about whether or not to give blood products. Although, again, when you speak to them about it, a lot of them don't really use it for that. It's more of in theory, it could help you make decisions. Triage at multi-casualty incidents. So you turn up to a big crash, there's multiple patients. They both get a scan. One's got free fluid, one doesn't. That one gets the blood, the other one doesn't. It's not a flawless system by any means, but it can help to differentiate patients in that circumstance. Um, Mechanism of injury and major trauma criteria are something that we discuss a lot in paramedicine. Um, where EFAST can help us with this is probably around those patients that might have some free fluid, but they haven't yet hit those criteria, those vital signs criteria to be transported to the major trauma center. Now, I don't think those patients are very common, but there is the chance that we're missing some of them. But I think the most important potential benefit of eFast is when the system is integrated. So when the paramedics are actually integrated into the trauma system in such a way that, like Queensland Ambulance Services managed to do, we get on scene, scan a patient, find them to be positive, call up the hospital, and the hospital trusts us that we've correctly identified what we say we have, and we bypass ED and go straight to theater or CT, whatever it might be. And that's what Queensland Ambulance has done, and they've managed to, they've published some data to say that they've actually cut off a significant portion of the time to definitive care by doing that, demonstrating a real patient value. Whereas in Victoria, I don't think we've been able to demonstrate that. Now, point-of-care ultrasound in cardiac arrest for paramedics is a really interesting one. So I use this in my practice largely to confirm what I already think is going on rather than to change my management in a great way. But again, just that statistical view on this is 7,000 cardiac arrests in 2021, 2022 out of over a million responses. Very small part of our workload. But as a specialist paramedic, this is where I focus a lot of my attention. And there's this idea, which I don't think is very well supported in the literature as of yet, that a lot of PEAs are actually pseudo PEAs. As one study found up to 75% they thought were actually pseudo PEAs. And you can obviously identify that with ultrasound. There's an association with ROSC and survival to hospital, but the evidence isn't there yet for prognostication in pre-hospital care. So as in we arrive on scene, the patient's in let's call it a Brady PEA. We put the ultrasound on, there's no contractility, and we call it. So that's not something that we do, and not something that I think is coming anytime soon. There's just a little bit of conflicting evidence out there about I guess the predictive value of that. And I think especially when as paramedics, we don't get our training in echo is basically one view. So it's very, very basic. And I don't think we're quite at a point where we can use this to make sort of strong prognostic decisions. Where it does help me in my practice is identifying those sort of subtle ROSC patients where no one can feel a pulse. And one thing that you've got to remember is out of that massive ambulance workforce that we have, the sort of 6,000 paramedics out there, 6,000 paramedics, they see less than one cardiac arrest per year per paramedic. So they don't have a lot of experience. A lot of them, it might be their first time ever feeling for a carotid pulse on a cardiac arrest patient. And so even though we have these ancillary signs of ROSC, like rise in end-tidal CO2 or change in rhythm, there's enormous comfort to be gained by putting a probe on and going, oh no, the heart's definitely beating. That's good contractility. We're confirming that we've got ROSC. Let's start our post-ROSC care. So that's where it really assists me in my practice, and I've found it to be beneficial in a number of occasions. Then ultrasound guided IVs. As I've already sort of mentioned, the failure rate is in the literature, is about up to 40% for a landmark technique. But again, paramedics working in these really challenging environments, like we don't have a nice, well air conditioned room, or probably heated room is a more relevant one, with good lighting. Like we're often working in these really poorly lit, awful cold environments where it's really challenging to get a good IV. And we think we're really good at it. And a lot of the times we can snag like a tiny little IV in the back of the wrist or something like that on challenging patients. But bringing ultrasound into it allows for a level of confidence, especially with really critically unwell patients, allows us access for things like noradrenaline. Getting a big line in the basilic or something like that really changes the game. And it's very uncomfortable to put in an IO in certain patient groups. Like it's a great tool in the critically unwell, but there's nothing. It's not really a replacement for an IV in a lot of circumstances, and so I found this to be an enormous help, for myself, allowing us access also to veins that we don't normally have access to. So some of the sort of greater saphenous veins in the legs or the basilic vein in the upper arm, really obese patients, which we're seeing many, many more of at the moment, and also pediatrics. It's been really fantastic for difficult cannulas in pediatrics. Um, and I shouldn't forget about arterial line insertion. Of course, our Flight paramedics are doing that, and there's good evidence to say that using ultrasound improves your first pass success. Let's talk a little bit about the different equipment that's out there. Ambulance Victoria uses the Philips Lumify at the moment, which is a great bit of kit. It's pretty technologically simple as far as some of these devices go. It's sort of more like the cart-based machines, I think, than some of the other examples up there, like the Butterfly or the Vscan Air. Um, the key sort of feature of all of these handheld devices that they bring out to paramedics are that they should be sturdy. They should be able to withstand dropping and being stepped on and all sorts of things, because we are notoriously terrible at keeping things safe when it comes to equipment. They do get dropped, and they do get dipped in all sorts of awful bodily fluids and terrible things. There's another number of different devices out there. Like there's loads of them, and there's more every day. Every time I turn around, someone's come out with a new device. But for the vast majority of Australasia, the Philips Lumify and the Vscan Air are the ones that are being used. And the key things that we need in one of these devices is a battery that's not going to give out, because you know and especially in some of those rural locations, you can't find a wireless charger to put your ultrasound on that only charges on a wireless charger. Like it can be really, really challenging to keep these things charged when they're getting daily use. Um, and yeah, obviously the protection aspect to it. Um, so there's a lot of research out there at the moment looking specifically into paramedic use of ultrasound. There's my own study from a couple of years ago, which I already spoke about. Naeem et al. From the UK has done a lot of work looking at London Air Ambulance and their sort of governance and quality assurance systems. One of my all-time favorite studies by Peterson, from one of the Scandi ambulance services, they trained hundreds of paramedics to do lung ultrasound on medical respiratory distress patients. And it was like a bit of a landmark study for pre-hospital ultrasound, in my opinion, um, and found very much that it was useful and did improve their ability to correctly identify the cause of respiratory distress. And then there's a couple of studies out there with very small sample sizes looking at out of hospital cardiac arrest, the use of ultrasound for it. But that's, as I said, that's still a very limited data set for the moment. So we'll move on to talking a little bit about some of the research that I've done. And I found out just this morning that my first study, this one here, is being published after 10 months of peer review. If there's any researchers out there, I'm sure you can feel my pain. But essentially, it was a qualitative study looking at the use of ultrasound by paramedics in Australasian ambulance and retrieval services. So the aims of the study were basically to assess who's using it and for what in Australasia, any sort of training and governance issues that they were experiencing, and then also just to explore the barriers and enablers of paramedics using ultrasound in this country. So there was a total of, let me get this right because it's embarrassing if I don't. Yeah, 10 ambulance services in Australasia, so Australia and New Zealand. And I can't remember how many retrieval services there are. There's a number of them. I think it might be 8 or 9. We got a response from every single ambulance service and only one retrieval service, sadly. But the inclusion criteria for this study was basically services where paramedics were using ultrasound. So a number of the retrieval services are physician nurse or physician midwife staffed, and so they would have been excluded for that reason. Out of the 10 ambulance services, only 2 of them were not planning on introducing ultrasound or didn't currently have ultrasound being used by paramedics in any capacity. And the rest of them all either were using it or were planning to introduce it in the next 12 months. And then the single retrieval service we spoke to was also using it on their helicopter. So of that number, 5 of the services, ultrasound was being used solely by intensive care flight paramedics. 2 of the services were using the specialist sort of ground-based intensive care paramedics, and 2 services had the community paramedics, so the low acuity specialists. I don't know how many of you sort of appreciate qualitative research. I really don't, which is sad for me being a qualitative researcher. But I'm just going to talk to you a little bit about some of the themes that we developed, because there was some interesting discussion points to be had with the participants. So the first big theme from this research was this idea of the pillars of point of care ultrasound, and that all stemmed from some work done by Carolyn Cormack, who's a sonographer educator here in Australia. Basically being like there's certain elements for a point of care ultrasound program that need to be present for it to be successful. And they are education, infrastructure and administration, and governance and quality assurance. And these things just came up time and time again with the participants, where either they weren't present and they were identified as the reason why they weren't being successful, like the programs weren't being successful, or they were present to a really high level and they were identified as the reason it was successful. So that was a really important finding. Culture change in paramedicine. Paramedics are sort of a weird profession in Australia because we're very new. We've only just become professionally registered, and we have some sort of cultural precepts that are a little bit difficult to get rid of. And one of those big ones is paramedics don't diagnose. That's been sort of an adage in paramedicine ever since, we're going way, way back. We don't diagnose things, we just treat symptoms. And I think the introduction of ultrasound sort of clashes a little bit with that adage, where you're actually able to truly see diagnostically what could be wrong with somebody with this device, whereas previously we're just guessing a lot of the time. Educated guesses sometimes, other times not. And that sub-theme there under culture change is called ingestation, and that's just about us being new as a profession and still trying to find our identity in that space. And then the next theme, system buy-in, and this one's really key. This is like one of the main important outcomes of this study was that these programs of paramedics using ultrasound are kind of destined to fail without buy-in from the hospital, and specifically buy-in from the physicians in the hospital. Like, we really rely on hospital hospital buy-in to the program, both from an education standpoint, but also from feedback, a little bit of trust as well, that we're doing it to a high enough standard that they can respect what we're finding and actually take it into account. Um, and systems. There was a couple of systems that talked about this in terms of the hospitals being quite resistive and being like, paramedics shouldn't be doing ultrasound. Like, we don't want to hear about it. We're just going to redo it at our end. Versus some systems where they were really supportive and they get you involved and go, oh, show me your images and let's rescan with our machine and we can talk about it, being very, very beneficial to the paramedics. And finally, the last theme is what's the worth? So from a health economics standpoint, this is not a cheap thing to teach 500 paramedics to do. And, if you want to take it even broader, and if you wanted to give it to all paramedics, your 6,000 paramedics, to teach them how to do this skill to a high enough level that you can trust them to use it appropriately is a very, very expensive prospect, both from a training standpoint, but also from a infrastructure, like having someone available to audit the images, that kind of thing costs a lot of money and time. And so we have to ensure that when we're creating these programs, that they're linked to patient outcomes. Like, it can't just be oh, we're better at assessing things. It has to provide a true patient benefit so that we can identify its worth and then focus the appropriate amount of resources on it. So just gonna, I'm not gonna run through a million different quotes with you, but I just want to give you an example that I think really clarified this for me, like a really stark spectrum of two different services in this study. So service number one, I'm extremely embarrassed to say we are not ensuring competency. What paramedics are actually describing is an observation of inappropriately performed, poorly governed point of care ultrasound in the pre-hospital environment. And then service number two, every one of our ultrasounds is quality assured in depth. And so we put the paramedics through exactly the same education that the physicians do, because you can't compare apples with apples unless you do that. 2 minutes on scene saves 45 minutes downstream. That's what we tell people. And we've got some work to show that it does move people through to the operating room and to CT faster. Now think about how starkly different those two examples are. One with no sort of adherence to the pillars that we're talking about before, this feeling of embarrassment that it's not being done to a high enough standard, and no sort of linkage to patient outcomes, versus service number two, benchmarked against what they're doing in the hospital, and with a clear defined patient benefit. So that's the study that's just about to be published in SJ-TREM. Woohoo! Study number two, which I've completed data collection for and analysis, but it's sort of the results are embargoed, so I can't really present them to you today, but I'll sort of imply what they were. So this was the study's called Diagnostic Accuracy of Out-of-Hospital EFAST by Specialist Paramedics Compared to Hospital Imaging in Major Abdominal Trauma. So this was a retrospective cohort study of pre-hospital EFAST scans performed by specialist paramedics from 2015 to, I think it was 2023. So it was a really significant time period, and it's linked data between Ambulance Victoria case sheets and Alfred Health patient care records and radiology reports. And the aim of this was to assess the diagnostic accuracy of the scans, basically, but we compared them versus the ED EFAST scan and then versus CT and laparotomy as the sort of gold standard result. So essentially what we found was that paramedics weren't performing the agreement with the hospital imaging was quite poor. With ED, it wasn't quite as bad, but certainly the results compared to CT laparotomy were not good, which I think represents, again, some of the lack of education, training, governance that we have in this ambulance service. The next study was looking at exactly the same data set. So it's sort of 800 patients with confirmed abdominal trauma, looking at whether or not a positive EFAST scan impacted time to definitive imaging or surgery in a major abdominal trauma. So same link data set, and we did sort of a regression analysis to look at whether or not a paramedic calling up the hospital and going, yeah, I've got a grossly positive scan, see you in 15 minutes, made any difference to their time, and it didn't. All right, that's pretty much where I'm up to with my research. I've got a couple more studies in the pipeline, but those are sort of the big tickets for the moment. Next, I thought we'd do a couple of cases from my own practice. So two cases to start off with, one high acuity and one low acuity. And the fact that they've all got COVID sort of dates this a little bit, but you'll have to bear with me there. So case number one, 40-year-old male. I was called as the second tier response by an ambulance crew on scene for a patient in severe respiratory distress. Vital signs wise, they were respiratory rate of 40, speaking in phrases, SATs of 82% on 15 liters, blood pressure's a bit borderline, heart rate's 150 in a sinus tachy, GCS of 15, and sort of borderline febrile at 37.8. The crew on scene, so the original ambulance crew on scene, said the chest was clear on auscultation. History is from the patient, last night at 10 p.m., got really short of breath all of a sudden. Mum called the ambulance. I didn't even want you guys to come. He's got no past medical history of a respiratory nature, does have a history of IVDU and ice abuse, but hasn't used it for 48 hours. So enter me with my ultrasound. So just to annotate you for you, I'm not sure how the quality is on your end, but this is the left side of the chest. We've got two anterior lung views where there's clear multiple B lines in two views, and then in the at the left base at the PLAPS point, we've got a small to medium-sized pleural effusion. Then on the right side, same thing, B lines, plus, 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 and a small to medium-sized pleural effusion. So I thought, what the hell, I'll try and get a cardiac view on this guy. And because he was sitting up, I couldn't really position him properly in the ambulance. He wouldn't tolerate being laid back at all. So it's not a very pretty view of the heart, but honestly, that's pre-hospital care in a nutshell, is often these images aren't pretty and you can't position the patients. And I'm not going to lie to you, I didn't pick this up when I did the image. I just thought that heart's moving real quick. Can't make it out very well, moving on. But in this picture on the right, where that arrow's pointing, I think you can see a sort of large vegetation coming into view. And when I arrived at the hospital, images in hand to show the staff, they flicked through it and picked that up and went, it's an endocarditis. So what we did pre-hospitally was put him on BiPAP, which got his SATs up to 94%, put in 2 IVs, and got him into ED, as I said, with the images rolling for the handover so that they could see straight away what I was seeing. Diagnosed a patient with endocarditis and pulmonary edema secondary to that. He was RSI'd and arrested on induction, but they quickly got ROSC and he was transferred for cardiac surgery. Next case, 50-year-old male. This one's a little bit more low acuity. I was just the closest car to a 50-year-old male with shortness of breath. He's COVID positive, day 7. His obs, you could see them there. They're kind of unremarkable, to be honest. Other than, his respiratory rate being slightly up and his SATs slightly down, he's a smoker, so I wasn't too worried about that. But as I arrived to this address, I realized it's the fifth time I've been to this address in 2 weeks. So this guy's called us multiple times, same guy, and I've been to him 3 of those times. So I know exactly who I'm dealing with and what his problem is. And he meets me at the door with, yeah, I know I've got COVID, but I just wonder if there's anything else the hospital can do. So it's 2 a.m. or something. I've had a hell of a night. I'm grumpy. My biases are in full effect. But I think, do you know what? This time I'm going to pull the ultrasound out and have a look, because I hadn't done that the previous times because he was COVID positive. And I honestly was expecting to see absolutely nothing on this guy. I thought, I'm done with you. You're fine. I'm going to leave here in 5 minutes and never see you again, hopefully. But you can see there, he's sort of got this consolidation in his left sort of plaps point, and then around L6 is sort of around the back a bit more, and you can see a little bit more of it there. So based on that information, I spoke to our virtual emergency doctor, and they said, "Nah, bring him in. He needs IV antis and a bit of follow up. We can't just leave him there." So that was a bit of a nice save. I know it's not like a very exciting one, but for me, for a patient who I was almost convinced was not going to hospital under any circumstances, it was an interesting sort of moment for me to go, "Oh wow, look at that! Like that's very compelling." And lastly, another COVID patient, 70-year-old male, short of breath, recently diagnosed COVID positive, went into cardiac arrest while on the phone to 000. He was found to be in an agonal PEA at a rate of 10, a past history of type 2 diabetes and hypertension, but lives at home with his family. He's independent. He's normally a pretty well man. When I arrive, CPR has been underway for probably 15 minutes by Ambulance Victoria and some fire rescue, some firefighters. And the only history from the family is he was short of breath for a few days. We stood him up to walk him to the car to take him to hospital, and he's collapsed to the ground. So this is to give you a bit of an idea, because I don't know how often you guys get to see this, of what these scans look like in cardiac arrest. So this is actually using John O'Henry. I don't know if he's actually on the line. This is using his vScan Air. It's just a sub-xiphoid view. It's not pretty, but you can see on the left image that, that's what it looks like with CPR. You can kind of get the heart in view, ready for the compressions to stop. And then once the compressions stop, you can see that standstill there, no movement at all. And then this next image was, at the next cycle, we got a ROSC. And, again, it's not a pretty picture of the heart, but you can see the ventricles moving, which is all you really need in this circumstance. Like, it doesn't need to be a perfect image. All I want to see is that ventricle contracting. And that was a ROSC. And we got him to hospital. I also did a lung ultrasound on him because it's just something that I like to do. And you can see he's sort of got diffuse B lines, but they're a bit patchy. They're not sort of that homogeneous distribution where they would be everywhere if it was like a pulmonary edema or something like that. They're sort of more of that COVID look where they're a bit unevenly distributed. There's a little bit of subpleural consolidation there. Unfortunately, this could very much be from the CPR, could be lung contusions, which does happen definitely after CPR. We often see these sort of patterns with B lines on the ultrasound. But for the sake of this case study, I'm choosing to believe this is COVID. All right, that's all the case studies I've got for you guys. Hopefully that gave you a little bit of insight into what pre-hospital point-of-care ultrasound might look like in Victoria at least, and I'm happy to take any questions.